Good morning.
Good morning, good morning.
Nice to see you again.
Yeah, thank you very much and welcome to TCT India and the greetings from Apollo Hospital, Hyderabad. We have a very interesting case for you, a left main, very critical left main bifurcation case with additional lesion in the LAD, totally occluded RCA. First, let me introduce my team members, Dr. Manoj Agrawal, you might be knowing, the director of the cath lab here, Mr. Ajij, the consultant cardiologist, Subhas, and Sister Jamna, and our technician Reddy and Srinivas. I'll ask Dr. Subhas to present the case. Subhas.
Good morning, respected chairpersons, teachers, and my dear friends. Here is a next slide. Here is a 83-year-old male presented with typical anginal pain and exertion. For the past 1 month, he is not a known case of diabetic hypertensive. Next. His ECG showed ST elevation in AVR with reciprocal changes in all other leads, and echocardiogram was done, which was normal. So, because of ECG changes and his symptoms, we went ahead with angiography, which showed. Here you can see RAO caudal view. There is a critical stenosis in the distal left main, which is almost 95%, which is also involving the ostial LAD and ostial LCX. Almost very tight lesions. Next. In a cranial view, you can see the aneurysmal segment dilatation of the mid to proximal to mid LAD, and also there is a tubular lesion in the mid LAD. Next. The same findings, you can see the distal left main, which is having a critical stenosis and also mid to proximal segment of the LAD with the aneurysmal dilatation. Next. Another cranial view, you can show clearly that the distal segment of the left main is very critical stenosis. Next. Here you can see the RCA is having a total occlusion with the bridging collaterals. Next. So we have calculated a syntax score for this case, which showed syntax 1 of 41. Then next. So according to the guidelines, it shows that triple vessel disease with the left main, distal left main especially, it comes under for class 3 and class 3B for in favor of PCI. For CABG it will be class 1. So then next, syntax 2, it shows PCI for 4-year mortality around 24% and CABG for 4-year mortality almost 26%, which is almost similar between these two, PCI versus CABG. So next. Our plan is to do a distal LAD stenting followed by DK crush bifurcation stenting under OCT guidance, and in this case DK crush is preferred because PCA of the distal left main bifurcation using a planned DK crush 2-stent strategy resulted in a lower rate of target lesion failure at 1 year than a provisional stent strategy according to the DK crush fight trial. So next, we will present the case and Dr. P.C. Rath.
I think you saw the case, very complex lesion, and 83-year-old. We first offered him bypass surgery, but he vehemently opposed. He didn't want surgery. He wanted interventions or medical treatment. So we explained the risk, and he opted for this. So that's how we are here. Before we go live, we just wanted to, what we did is, just go ahead, show this. First,
can I ask a question?
Yeah, go ahead.
So if you go back to the RAO caudal, it looks like there's an occluded obtuse marginal
Yes,
range.
right. You are absolutely right. Obtuse marginal is totally occluded, getting collaterals from LAD and distal circumflex.
So if that's not going to be opened,
That we are not planning to open.
The circumflex itself really doesn't supply that much of the LV.
Yeah, but circumflex ostial is diseased and it's a large circumflex.
Sure, but I guess I'm just playing devil's advocate. I do exactly what you're saying, but even if there was disease and restenosis in the circumflex, which itself supplies very little of the obtuse marginal supply, it really is important to get a good result in the left main into the LAD if we're not going to open up the OM. I'm not worried about restenosis in the circumflex, which really only supplies the AV groove.
No, it's supplying the RCA also is RCA totally dependent on the circumflex supply. So it's very important, circumflex and LED both are important, and circumflex is important because it's a dominant circumflex supplying the occluded RCA also, and part of the OM. So I think it both needs to be addressed. Just so in the meantime, whatever we did, I just want to show you. First, first what we did was very tight, so we dilated the ostium of bifurcation with 1.5 balloon and went down, dilated the critical LED with 1.5 balloon, and then we tried to cross the OCT where OCT didn't go, you can see it buckling down, and then what we did is we took a 2.5 balloon and dilated both distal LED, mid LED and proximal distal circumflex, and after that we did the OCT of the whole LED and left main. You can show the OCT picture. We have Mr. Pavan from Abbas, who is expert in OCT interpretation. He is there, he helped us.
Yeah, and just before you go to that, just for the audience, I think that sometimes if you're going to be working on that mid to distal LED or the mid LED, with that tight of a left main, you often need to balloon the left main first to get flow, especially with the right occluded, the OM occluded, because the patient may not tolerate these long imaging runs.
He had angina, and that's why we went ahead and dilated with 2.5 balloon. After that, it stabilized. You are right, he had angina. With a tight left main, so after ballooning it stabilized. Now see the OCT, go ahead and show the OCT. That's what we are seeing in the mid part of the LED, and that's the aneurysmal part. And go ahead and show the left main, and show the ostium of the circumflex. So that that's the left main. You can say mostly it's a fibrous region, not much of calcium. There's some clots here and there, but look at the ostium of the circumflex that is diseased. So
Yeah,
it's
I don't know if you can tell. I mean, typically with the left main, to really tell what's going on at the ostium of the circ, you need a separate run down the circ, and that's true with IVUS and OCT. You'll get a sort of sideways look at it, but you can't fully tell what's going on.
Okay, but there is a angiographic, also there is a ostium of the circumflex is involved. Here also OCT it is there. I didn't do it OCT from circumflex to left main. But what I am planning is it has to be treated, and because it's an important vessel, we are planning to do double stent technique. First, I'll put a stent in the circumflex, the 2.512. You have any concern about the technique, what we are doing?
Yeah, I mean, my only concern, two things. One is I think if you're thinking the circ is a large dominant branch,
Yes.
then a 2.5 is likely not the adequate size for it. And if you thought that that was the right size, then I would recommend doing an imaging run first to be sure of that. And the second is we just didn't get a chance to study the films enough to determine how much the circ itself is actually supplying, because it was a very quick shot of the right, so it's not clear to us from here. I don't want to make you go back and forth and do it that way. But I think if you're going to do the circ,
We'll image it. We'll image it if necessary. We'll
Yeah.
do an additional dilatation.
Yeah, that makes sense.
Because patient was, he was having angina and all these things. I didn't want to
Yeah,
do it
again,
again
I
so
agree.
much. So
But that's one of the reasons why, honestly,
Yeah.
if he's unstable or having angina and he's sick, some might just recommend stenting across, and then if you have to do provisional with the T and protrusion, then that would be a very reasonable strategy as
provisional,
well.
but it stabilized after that. So we are going ahead and using the usual double cross technique. I think the result is good. Decay cross will see, and now he stabilized after dilatation of the left main with 2.5 balloon, and that's the.
Yeah, I think that was the key, is you have to get some flow. So, yeah, go ahead and proceed.
Dr. Rath,
Yeah.
Dikshit here.
Yeah,
Yeah.
tell me your case only.
No, that's okay. But I just was wondering whether the patient has any MR,
No MR, LV is normal.
because the circumflex is occluded.
No
RCA
MR.
Okay.
Down a bit.
Mm-hmm.
No. No, test.
So
The
if-
stent to circumflex, ideally it should be 1 or 2 millimeter into the left vein, just inject little this, yeah.
So if you're picking a 2.5 stent, you have to
Yeah.
make sure you know the sizing matrix of the stent, because that circ could be as big as 3.5, and not all the 2.5
No, it doesn't
stents.
look like the 3.5, it's, I can see it here, go ahead.
Not all the
Well,
stents will go up to that
yeah.
level, and so then you'll end up with an undersized
That
stent
is,
in the ostium of the circ.
no, it doesn't look that big.
No,
It's
no, I-
just 2.5. We'll check it.
No, I'm just making the point to the audience,
Yeah,
that's
yeah,
all.
fine. So now we just dilated the stent 2.5 with 16, and we're just doing the,
So before crushing, it's also important to just do a gentle test injection to make sure you don't have a distal edge dissection in the
Yeah.
circ, because if
yeah,
you do,
that is okay.
then
There
you
is
would
no
have to
dissection
take
and
care
then-
of it.
Okay, fine, and then just do the crossing. No, cross it. Take out the wear. Take out the wear. We have to take out the wear, and then we'll cross it. Just 1 minute. Oh, okay, cross it now. Go more. Okay, it's a 3 millimeter, 3.5, 12. And we cross the first cross here, and we'll see the result. Okay, fine, just inject. Just wait. Inject. Go to the spider. Just wait, take out the balloon, the picture will be more. Balloon where we'll take it out. Okay. P column. Give a whisper where. Now that's the first cross, and we have the stent is in the 2.512 stent is in circumflex, and we'll recross it. We'll take it out. No, I'll take it out. Better. I took out the balloon also, then I'll put a recross it with a whisper wear, give the whisper wear.
So far, you guys are textbook DK crush.
Yeah, that's what. The decay class takes little time, but the end result is definitely better. And patient, initially we were thinking of mini cross, but the patient stabilized after dilatation, so I can afford to take time and do a decay cross.
But that's actually one of the reasons why it's good to have a 7 French system at least for a left main, even from radial. I'll do it that way because if the patient gets unstable and you need to stent quickly with 2 stents, then you can put them both in at the same time through a 7 French, whereas a 6 is very challenging.
Yes, 6 will be difficult because we are taking 3.5, size of the left main is 4, we have to do a pot with 4, so 3 point. Just this tip of this wear is gone, I don't think it. Test.
Since I'm in the United States and I have no penalty for cost, I like to use a microcatheter, backing up to recross into the circ just because it lets me have a little more control of the tip of the wire.
The one thing you have to avoid, and if you watch his hands on the upper right, is he's not spinning the wire. It's very, once he gets to where he needs to be, it's just very gentle movements, because if you can get a lot of wire wrap, then it becomes challenging to get the balloons back in into the struts. The other thing is that in the classical provisional technique, you want to sort of wire a distal stent strut. For DK crush and 2 stent techniques, typically you're going more proximal. It's a more proximal strut so that you get adequate carinal coverage. And because you have the OCT, you can actually see where it actually is if you want to do it that way.
Just
This is always the most stressful part of a live case, right? Everyone's watching you trying to wire. That adds a level of difficulty that makes it nearly impossible, right?
give me one more where.
Do you have any preference while crossing the struts of a crush stent?
Hmm?
Do you have any preference of wire to cross the struts of the crush stent?
So there's a question of which wires do we like to use to recross into the circumflex. I like to just use a workhorse wire. I use ProWater Xi'an Blue. If I get difficulty like this,
Just
I may use a polymer tipped wire, but I always worry that
right.
with the polymer tipped wire, it may have gone under a strut. And it's hard for me then to separate if I have trouble advancing the balloon. Did I go under a strut, or is it just because there's tortuosity or I need to go through the stent? So for that reason, I like to start with a workhorse wire, and I'll really, try like the operators are doing here.
One more.
Sometimes the wire that you can use that can help these situations too is like a Miracle 3, because you have very good one-to-one torquing and you can see it really well, and it has a little bit stiffer. So I'll sometimes go to that before I go hydrophilic to cross through a strut.
I mean, one of the
Let's change
keys
the
is,
where the tip I'm not happy with, so I'll just change it and see.
one of the keys is to have a core to tip wire, because it will maintain the curve better and will not deform and form a J
Tip is
when you're hitting one of the struts. So almost as important as it being hydrophilic and polymer tip is actually core to tip, because as Ajay said, a Miracle or something that gives you that torque control will be helpful here, because you have a pretty good lumen. You have a good lumen, right? It's just a matter of getting to the spot you want.
Another thing to talk about that we didn't before is, whether the patient needs any type of hemodynamic support with a occluded right, occluded large OM, tight left main. The good news is the EF is fine. The MR question was also relevant as well. And his blood pressure starting off, at least we could see on the screen, looked great. So typically these cases can be done without support, but if there are any issues, then you have to.
We have, we don't, but we have in the standby of, we have put we have kept open the femoral artery. IVP is there. We have a femoral line the left side also.
Oh, so you did. You took a safety line on the other side.
We could probably debate for a very long time
Yes.
of hemodynamic support, but like Ajay, I usually reserve even complicated anatomy for the person who has impaired contractile function, but particularly those who are decompensated. And nice. But I think that's where trying to make a thoughtful decision is very important. I know the protocol at Columbia is to check out the patient. If they're sick, or you're not sure whether they're sick, you do a right heart cath and try to understand
Okay,
what
good.
their hemodynamics
Now
are like.
it's, so it crossed, and I always prefer a whisper where to cross this, and I saw it crossed. It's just question of time, and a little takes some time from the crossed where, strain to cross it where, but does cross. You can always keep changing the where, but I feel a hydrophilic where is better. So we are going to dilate with a short balloon, 1.5, and then
But this is also where the DK crush becomes important, because if you don't dilate this and then you crush it and you have to do the same crossing maneuver through the LED struts, it becomes a lot more challenging. The one thing about the Whisper that's great is that it crosses well, but in these long cases, especially with exchanges in and out, you do have to watch your distal wire position to be sure that you don't have, you know, a distal wire perforation that can occur, and that's often why we will swap out.
That is one of the worries. Many of this hydrophilic wear is notorious for that, and just take it out. And you can see the tip of the wear, at least here, turned around is better, more safe, I think, if you have a. So we take a balloon now for the circumflex. We take a 2.5, 12, and for the left main we take it a 3.5, 12. We'll give a kissing. Give it quickly. Give it. It's you know, this is decay cross. Probably it takes a little more time. So in a live case, when you have a OCT, complex lesion and all that, I think decay cross, by the time you finish, your time is over. So that is another reason why most of the time decay cross is not shown live. And this is, anyway, I think we'll be able to finish it, and you can see the end result. And we'll, in the end, we'll show the OCT also. This time, we'll take a run from circumflex. As Ajay pointed out, that circumflex tint, we want to see if it is, this is what size? Oh, the first balloon is left main. I'm putting that 3.5 and 12.
Maybe a show of hands from the audience. How many of you are doing DK crush for your bifurcation strategy? How many of you actively avoid doing the DK crush for your bifurcation strategy? Nobody admits to that. But there are a lot of people that do, because it's complicated.
If you find that this angle of the circumflex is actually retroflexed or not something that's favorable in this, what's your second favorite stent strategy? And if there was not much disease, for example, in the origin of the circumflex, do people prefer a provisional approach with a tap or a reverse culotte? So maybe that's the second question. If you're taking a provisional approach because the side branch is large but not diseased, who prefers tap? And who would prefer to just finish off a culotte?
Both first kissing by 3.5 12 LED to in LMC LED and 2.5 12 LMCA to circumflex. That's the first kiss. So we take it out.
Now, if for whatever reason that circumflex balloon doesn't cross, you can always put the balloon up in the LED. You get an anchoring for your guide, and then it crosses easier into the circumflex.
Where is it? Okay. Okay. We take it out. We take out the. Just check the injection. That's okay. We can take out this wire balloon of. I'll take it out. This everything of this L6 wire and balloon I took out. I'm taking out this balloon of LED. Now we'll put the stent.
And by OCT, it looked like it measured, it was 40 something?
4.5, exact 4.5, 4.6. Just give injection.
No, I mean the length of the stent in the LED.
Length of the stent in LED, the first one was 23, we put the mid part of the LED. Now we are going to put 3.5 and 23. Go, give it. planning to overlap this stent. We have calculated the size, and it's 23 will be okay.
You
This
already
is-
stented that mid LED? That was already
Yeah,
stented?
yeah. We'll put a little proximal.
And then just making sure you don't double jail the diagonal
yeah.
because it's a big diagonal.
Cranial, just see. We'll bring it back little. It's okay. Inject.
Yeah, so you're well clear of that.
Okay, see. I think we'll stand boost. Stand boost, please. Adjust. Okay. No, just position it properly. Okay, take it in this view. Take it in this view. Go to this view, you can see it. Inject loud. Forget about stand boost. Inject. No.
Which stent are you using?
Yeah, it's we are missing it little. We are about what is this state with Giants expedition. Inject.
The reason I ask is because the Zions lines up directly with the marker, whereas some of the other brands,
Okay.
it's a little bit inside the marker. So when you're lining it up, you just need to know that
Okay.
for each specific brand to be able to deploy it properly.
Put
The Zion stance is the only one that where that was
Open
on
the
the marker.
open. Inject.
Yeah, it looks good.
Overlapping is there.
Yeah.
Okay, fine. Its overlapping is there, and go ahead and put the stent. Deploy the stent is go up to 10, 12, 14, 16. Okay, fine. Okay, then we'll do the, I'll take it out. Let's do the part.
So it's an important step to make sure that you're opposed in the left main, because clearly the left main is going to be bigger than 3.5. And
Just
if you
in
don't,
the-
then you can get behind the stent struts with the wires. So
Okay, so the spider, get for the pot you get the balloon.
One thing too is your guide is
Leave it.
very close to the proximal portion of the stent, so just to be mindful
Yeah,
of
yeah.
that.
We have to be careful so that it doesn't push the stent. So this is the first part, we have to do it. And before I try to recross again to circumflex. And that in this decay cross, twice crossing,
You might be right.
twice crossing, once with balloon, once with stent, twice pot, and twice kiss. So these things you should remember. Wait. Okay, fine. Just inject. So the P caudal. Okay, fine. Go. This is a 4.5 balloon. 8. This is for the pot. Okay, deflate.
So I'm
Inject.
sorry to go back to my original point again, but I think if the
Inject.
left main is 4.5, then and you know there's a huge OM that's occluded, then there's almost no way that the ostium of the circumflex can be smaller than 3.5 and even 3.0. So I understand that this will be able to be dilated and imaged, but typically speaking, if you think the left main's 4.5, then your LAD stent is going to be either a 3.5 or a 4.0, and your circumflex will be a 3.5 or a 3.0.
So anyway, as I told you, Ajay, I will image it and see it, but here it looks like angiographically it's, give it, it's okay, but we can check it before, that's what imaging is for, to check the final result and optimize the result in this left main bifurcation. So now again I am taking the whisper wire to recross again. Second recross is little more difficult because more metals will be there, and I hope I'll be able to cross it, and after I cross we'll give again a second kiss. Give the, and after that I'll do the OCT, this time from circumflex to left main as suggested by Ajay, just to make sure it is size. Inject. It's best to go from to the LED and then come back and try to enter distal distal part of the stent.
So we're running a little short on time, so just going to let you know that we probably will have to cut out in about 3 minutes. But
we are going to show us in the end 10 minutes, I was told, and then I'll show the final result. You are going to come back to us after you finish, I think that's what I was told, 20 minutes, and then after that 10 minutes, up to 10 minutes to show the end result. So if you have, you want to go to other places, you can go to Kims and you can come back.
the other thing we can do too, we're going to check on that to see. That's great. But the other thing we can do is
Okay,
no, that's great.
Yeah,
You're also coming
once
to the conference, so we can
we
show
can
pictures too.
have the lectures and then we can come back to
Yeah,
them.
that'd be
We'll
perfect.
come back in 10-15 minutes again back to you.
Perfect.
Inject.
But I can tell you that step would have been a lot more challenging had you not done that first ballooning and kiss. So that extra step was important.
Balloon, I think I'll inject. No, they want to show us the end.
No, we'll come back to you. It's okay.
Okay, give us the balloon 2.5 and 3.5. I told them to keep the balloon, idiots. Hello? I think they are off.
So that's a fantastic demonstration. So now what you're going to do is you'll go back and recross and kiss and then image. And what we'll do is we'll go to the lectures, but then we'll come back.
I left two where they just saw it. We recrossed again with the two,
Can you
and then dilated.
can you get his images, please?
Yeah, can you get the image now?
Yeah.
Just,
see you.
Can you see it?
Yes,
Okay,
yes.
we recrossed again with from the two stents, and then dilated the ostium, and we did a kissing balloon, and that's go ahead, and that's alternately we did it, LAD, and then OM1, then kissing, and then that's the stent, and go ahead, and then go ahead. The stent in the left main to LAD, and then pot, and then recrossed again, and recrossed, dilated the ostium, then again final kissing balloon, and that's the final result. You see the result, that is the final result. And then we decided to do the pot again, and with a 4.5 balloon, and that's the result now. You can see the result of absolutely circumflex looks very good. There's no pinching. LED. Then we put did the OCT for the left main, and you can see the result now. So the OCT result. We tried to take the OCT catheter across the circumflex. That's what Ajay was insisting. That is a small stent we put. But angiographically, it looks fantastic. But unfortunately, the catheter didn't go because there are two stents there. Catheter didn't go inside the circumflex. So what we did is we did the OCT from left main, LED to left main. Can you show this OCT? And just see what OCT, everything is perfect. Only you should look at the left main. Left main stent is not well apposed, and just show the point where the stent is not well apposed. That's the point.
That's
So
the advantage of angio co-registration. If you want to see at that point,
at
the
that
aneurysm,
point you can see it.
take
You
there
can
and
see you
there.
can see
Same
the
with
stroke
left
is
main.
not well apposed. So we decided we had did the pot with 4.5 balloon. So we decided to go and dilate with the 5 balloon. That's the 5 balloon near dilatation near the left main, and that in the final result. So the final result. That's the final result. Look at the beautiful result in left main bifurcation. Circumflex is very good. I can see it very clearly. There is no residual stenosis circumflex. So the other view, and next view, and that one, and that's the one, and that's the end result. And to me, angiographically, it looks fantastic. OCT-wise stent is well apposed, good result, and circumflex artery osteum is very good. Flow is absolutely perfect, no residual stenosis. So I hope this patient will have a very good result. And in this type of cases, complex cases, this can be done. Surgery, as I told you, that result of 4 years surgery versus angioplasty stenting almost comparable in this case. Now with this decay cross techniques and all that. I think that's the end of it.
Thank you, sir. Thank you
very
for
much.
showing. Congratulations to you and all the team, showing an excellent demonstration of DK crash. A big round of applause to Dr. Rath. Thank you.
Thank you very
Right,
much. Thank you to all. Thanks.